Good evening to everybody. Good evening to everybody. Babar, can you hear me?
Yes, I can hear you, sir. Good evening, sir.
Okay. So, candidate one, can you hear us?
Yes, sir, I can. I can.
Okay. So, once again, good evening to everybody. Welcome to Dr. Babar, who is a cardiothoracic radiologist working in Liverpool. And his session is going to be very special. He will give you, absolute pearls for what you have to remember and learn for cardiovascular as well as lung tumor. So that is what the Viva cases are going to be. I'm going to stop the share and Babar, over to you. We have got 4 candidates today. So you can take a break after 2 candidates and then 5-minute break, and then we'll continue for 2 more candidates. So over to you, and I'll mute myself now.
Thank you, sir. Thank you, Dr. Sami Khan. Dr. Sami Khan is our mentor. My name is Dr. Khalid Shakil Babar. I'm working as the clinical lead for radiology in Liverpool Heart and Chest Hospital. I will share my presentation with some presentation slides with all of you. Candidate 1, can you unmute yourself and can you see the slides?
Yes, sir, I can see the slides.
Thank you. Thank you, candidate. So this is the overview of today's session. We will initially talk about coronary and cardiac anatomy and its clinical significance. Then we will move towards imaging features of myocardial ischemia and infarction. Then we will do some exam favorite cases, some vascular cases and emergencies, and then some lung cancer imaging cases as well. So first we'll talk about coronary anatomy. So this is a very important diagram in terms of coronary anatomy. So important in cardiac anatomy, levels are important. So cardiac anatomy is discussed in terms of levels. So this is image of heart at the level of aortic root. Here you can see 3 cusps or 3 sinuses. Candidate 1, can you see my cursor moving?
Yes, sir, I can see the cursor.
Okay, thank you. So this is the right coronary cusp from which the right coronary artery arises, okay, and it goes into right atrioventricular groove. So this is anteriorly placed and it is at 12 o'clock position. So if this is a clock, this is at a 12 o'clock position. So this is very essential or key thing to remember. The right coronary artery arises from the right coronary cusp at 12 o'clock position. So this is the left coronary cusp from which the left main artery arises, and it arises usually at 4 to 5 o'clock position. Okay. So we have 3 coronary cusps, and the third one, this is the non-coronary cusp, which is at the level of interatrial septum. So you can see this is the left atrium, and this is the right atrium, and this is the interatrial septum. And at the interatrial septum, there is the non-coronary cusp from which usually no coronary arteries arise. The left main artery or the left coronary artery which arises from the left coronary cusp it then again divides into left anterior descending artery, which will go in the interventricular groove, and the left circumflex artery, which will go between the left atrioventricular groove. So we call these as triple coronary vessels, or we call them as um, three coronary vessels, which are, one is the right coronary artery, which arises at the 12 o'clock position. Another one is sorry. Another one is the left coronary artery, which arises at 4 to 5 o'clock in position and then divides into the left anterior descending artery as well as the left circumflex arteries. So these are the triple vessels, or we call it triple coronaries. Okay. I hope it is clear. Now we'll move towards a case. Let me share my screen again. So candidate one, can you see the screen?
Yes, sir, I can see the screen.
Okay. So I am going towards the level of the aortic root.
Yes,
So
sir.
this is the level of the aortic root. Okay.
Okay, sir.
And here at candidate one, can you mute yourself, please? Thank you. So at 12 o'clock position, at 11 to 12 o'clock position, this is the origin of the right coronary artery. And if you can track it, these are the axial images. So these are the focused axial images of the heart. So we usually take these focused images, we reconstruct these focused axial images of the heart. So it is traveling in the right atrioventricular groove. And then, so most of the right coronary artery, it supplies the right side of the heart. Okay, it mainly supplies the right ventricle. So this is the right ventricle. This is the right atrium. This is the tricuspid valve. This is the left ventricle. This is the left atrium. This is the mitral valve. These are the pulmonary veins. Okay. So the right coronary artery, it supplies most of the right side of the heart as it travels. So an artery, when artery will travel along a course through different structures, it will supply these structures. So as you can see, it is going towards the right side, the right coronary artery. It will supply most of the right side of the heart, including most of the right ventricle. Then it goes down. So now we are moving inferiorly. So it goes down inferiorly. It then supplies inferior part of the left ventricle through these branches. Usually the right coronary artery, if there is right-sided dominance, it divides into two terminal branches. One is which is the posterior descending artery, which supplies the posterior part of the septum and the posterior part of the left ventricle. And then it divides into another terminal branch, which is this branch, which is the left ventricular branch. It also supplies the inferior part of the left ventricle. So if you look at the course of the right coronary artery, it supplies the right ventricle by different acute marginal arteries, which are these small arteries, and then it supplies the inferior portion of the left ventricle. And it courses along the right atrioventricular groove. Now going towards the other coronary artery. So this is the left main coronary artery. And it immediately divides it is usually 1 to 2 centimeter long, and it immediately divides into this anterior branch, which is the left anterior descending artery, LAD. As the name indicates, it travels anteriorly in the interventricular groove. So this is the right ventricle, this is the left ventricle. It is traveling between the interventricular groove anteriorly. It has multiple branches. It has these septal kind of small branches which supplies the anterior septum. And also it has some diagonal branches Like this is a diagonal branch which supplies the anterior surface of the left ventricle. And here it is usually most of the time it spirals around apex of the heart. So this is the apex of the heart. It spirals around apex of the heart. So it supplies most of the left ventricular apex as well. So the left anterior descending artery, as the name indicates, name also has an A for anterior. So it supplies anterior portion of the left ventricle. Then we have this branch, which is usually a smaller branch, which is called the left circumflex artery. Sometimes we call it circ as well. It usually have divides into obtuse marginal branches and sometimes continues into an obtuse marginal branch, and it supplies, as you can see, it supplies the lateral wall of the left ventricle. So to summarize, we have three coronary arteries. One, the right coronary artery, which arises at the 12 o'clock position. It supplies the inferior portion of the left ventricle and most of the right ventricle. The LAD, the left anterior descending artery, which supplies the anterior portion of the left ventricle and the septum. And we have the third branch, which is the LCX, which supplies the lateral wall of the left ventricle. So this is the vascular distribution of the coronaries. So you should try to remember it. It will help you in cardiac MRI as well. And it is just like distribution of ACA and MCA and PCA in brain imaging. So this is similar to that distribution of the coronary arteries and the perfusion of the heart. This is extremely important for that. So we have covered the main anatomy, cardiac anatomy on CT scan. Now I will move towards the cases. Okay, this is slightly very bright. Let me move towards this case. Candidate 1, can you unmute yourself, please?
Yes, sir.
Yes, this is your case. Do you
Okay.
want to scroll?
Yes,
How
yes,
do you
sir.
want?
I'll ask for.
Yes.
Sir, I have requested the remote control.
Okay, your request has been approved.
Okay, sir. Sir, I'm provided with the CT coronary angiogram focus views, and first I will scroll from top to the bottom, and then I'll start commenting. Okay. Sir, I can appreciate that from the right sided or anterior cusp, the right coronary artery is arising, and the left coronary artery is not arising from its normal anatomical position, and it has the common origin with the right coronary artery. And then, as I uh, trace the right coronary artery, it is going into the atrioventricular groove, and then I'll trace the left coronary artery as well. And after having the common region from the anterior cusp along with the right coronary artery, it is coursing posteriorly, and then it is dividing into the circumflex and left anterior descending arteries. I will trace the course of both these vessels as well, and then I will they are showing a normal contrast specification, and then I cannot appreciate any filling defect within the visualized images. The pulmonary veins are also sir, unremarkable, and the lung wind and the bilateral lung fields in the confinement of the mediastinal windows are unremarkable. I would like to review the lung windows
Okay.
as well, and I will
Thank.
correlate my findings with the clinical with the presenting complaint of the patient, and convey them to the cardiologist for further work.
Okay. Thank you. Thank you, candidate 1. Let me go back. So you started really well. Described the anatomy really well. So just to recap what you have said, that the left main coronary artery or the left coronary arteries are arising from the right coronary sinus. Okay. So, candidate one, can you stop controlling screen?
Oh, sir, yes, I have given up.
Okay. Thank you. Thank you very much. So, just to recap, okay, so this is the right coronary artery, which is arising at 12 o'clock position from the right coronary cusp, okay, while the left coronary arteries, which usually arise as at 4 to 5 o'clock position, as you can see here, they're coming in close, but is not joining the coronary cusp, but they go anteriorly at join around the 12 o'clock position near the origin of the right coronary artery. So this is anomalous origin of the left coronary arteries from the right coronary sinus with a malignant course between the ascending aorta and the pulmonary trunk. So this is the pulmonary trunk here. Okay, so just to recap the anatomy, this is the pulmonary trunk. This is the left atrial appendage, and this is the ascending aorta, and this is, you can see here, the descending aorta. Okay, so if there is an anomalous origin between two pulsatile vessels, so ascending aorta is very pulsatile artery, and pulmonary artery is also very pulsatile. So these pulsatile vessels can compress this intermediate vessel, which is coursing through that. The malignant course of this vessel can be compressed. So patient can, when the patient is exercising or when the patient is running, they can suddenly go into syncope, or they can have dizziness, and it can cause sudden cardiac death. So usually in this case, you will refer it to the cardiac surgeon and review the patient, and sometimes they will reimplant the coronary arteries. Okay, so this is an anomalous course, which is called malignant, although there is no malignancy in it. It is just because it is associated with sudden death. That's why it is called a malignant origin and malignant course, and it needs intervention. It needs intervention in terms of surgery. That's why it is called malignant course. So, well done, candidate one. Let me show you one more case, candidate one.
Okay, sir.
Okay. Candidate one, do you want to scroll?
Yes, sir, I want to scroll. Sir, I have requested the remote control.
Yes, please. Yes.
Okay. Sir, I am provided with the CT, coronary angiogram, coned images, and I would scroll to the top, and then okay. So, so I can appreciate the contrast or specification of the uh, arch or of the ascending aorta, pulmonary trunk, right and left main pulmonary arteries. And then as I scroll further, hmm, okay, at 12 o'clock, the right coronary artery is arising from the anterior cusp, and then there is a no anomalous origin of the left coronary artery, and it is coursing between the pulmonary trunk and the arch of aorta, having the malignant course, and then sir, as I scroll, yes, further, mm, there is normal specification seen, and sir, I cannot appreciate the complete arch. I will look at it once again. The this is the left ventricle, and
Okay. Carry on. Well done. Thank you. You've done really well. You have corrected your mistake. This is really important. Um, so you have done really well. Again, it is a similar course, different patient, similar pathology. Here, there is just slight difference. This is not the pulmonary trunk. You can see the pulmonary trunk is up here superiorly. This
yes, sir.
is the right. Can you mute yourself, please?
Sir, I need to first give up the control, then I can
Yes,
mute
yes,
on.
please. Okay, so here again, you see right ventricle when it goes and forms the pulmonary trunk, there is a right ventricular outflow tract, which is here, which is also again a pulsatile structure. Okay, because it forms the pulmonary artery superiorly. So if the coronary arteries are coursing between right ventricular outflow tract and the aortic root or aorta, they are still called as the malignant origin. So here, this is the level of more. It is more inferior. It is the level of around the level of aortic root. So even if there is the malignant course between right ventricular outflow tract and aortic root, still it is called as the malignant origin and malignant course. And again, you have to refer it to surgeon, and if the patient is symptomatic, the patient might need surgery. Okay, and usually if we are doing a cardiac CT for coronary arteries, we will not cover whole aorta or aortic arch in it. It will be like overexposure to the patient. So if you will ask for it in the exam, it will give you negative marks. That usually it is not. It means you do not know the coverage of the cardiac CT. So cardiac CT coverage is usually we try to completely cover the left atrial appendage. Okay, so it is now left atrial appendage is completely covered because there can be a clot in the left atrial appendage and inferiorly up to the inferior margin of the heart, superiorly up to the left atrial appendage. So this is complete cardiac coverage. Okay, so if you will ask for an aortic arch in a cardiac CT scan, it might give you negative marks. Okay. Well done, Candidates. These were the uh, two cases for coronary anatomies. I think there is one more case as well for you from my side. Uh, are you there with me, candidate one?
Yes, sir, I am here.
Okay. Can you scroll this case?
Mhm. Sir, I'm requesting the remote control.
Yes, please.
Yes, sir, I'm provided with the coned images of CT chest, and I will scroll from top and then go to the bottom. And, sir, I can appreciate that there is a normal opacification uh, of the left atrium and pulmonary trunk, and then the right coronary artery is arising anteriorly from the anterior cusp, and then I'll scroll down, and I cannot appreciate the uh, origin of the left coronary artery, and I would like to uh, trace it. And okay, so I'm going down, and I can appreciate the left atrium and the right, the left ventricle and the right ventricle, but uh, I could not appreciate the origin of the left coronary artery or
Okay. Let me help you. So here you can see the
yes, here, yes.
yes, the
So
arrow
there
is
is
on
some,
the
yes, sir, there is some common anomalous origin, and it is sir, it is arising from the left. So it is going into the left appendage, and from here I can trace uh, and few anomalous
Okay.
branches, and from which
Um, Candidate one.
yes, sir, yes.
Yes. So the examiner of the FRCR exam are there to help you. So when
Yes.
they want to guide you, so let them guide you. Okay.
Okay, sir.
So what is this structure?
Sir, which one? This?
Yes, yes.
So this is appendage, atrial appendage.
Okay, so atria has two appendages. One is of the right atrium, the other is of the left atrium. The left atrial appendage is usually it is triangular and it is trabeculated. Usually the atria are smooth walled while the appendages have trabeculations. So this is the left atrial appendage, which is triangular, and it is they are usually attached with the atria. Okay.
Okay, sir.
So now moving back to anatomy. So anatomy is extremely important. So if you go down on this, what do you think? What is this structure?
So this is sir, I cannot see the cursor. Are you asking about this one?
Yeah, yeah, yeah.
So
So
this is the pulmonary trunk.
this is the pulmonary trunk. Okay, go up superiorly, scroll. You're controlling the screen here.
Okay.
Oh, go down, go down, go down. Yes. So now what do you think? What is this structure? The same
So this
structure
is
is this one.
pulmonary. So this is pulmonary trunk.
Yes. So this is pulmonary trunk. So
Okay.
in CT or MR in cross-sectional imaging, you can always scroll up and down to confirm your anatomy. So if you are confused in a case, you can always scroll up and down to confirm where you are.
Okay.
Okay, so this is a troubleshoot for you. If you're stuck somewhere, you do not know what structure it is, go up and down and then correlate. Okay.
Okay, sir.
So yes, so this is a pulmonary trunk. Now can you trace the origin of the left coronary arteries again, please?
Yes, sir. Sir, it is arising from the pulmonary trunk.
Yes, good, excellent. Now, can you stop scrolling and
So should I give up the control?
yes, yes, please.
Okay,
Thank you.
okay, sir.
Thank you, candidate one. So this was a difficult case. I'm sorry I gave you a difficult case, but I wanted to see how good you are, and you are really good, candidate one. So here you can see this is the pulmonary trunk. So it is really important to identify the anatomy. I know this is a cone view, so anatomy can be difficult in here. So this is a pulmonary trunk, and it is divided into right and left pulmonary arteries. Uh, so this is still the pulmonary trunk, and here you can see the left coronary artery is arising from the pulmonary trunk here. It doesn't reach the 5 or 6 o'clock position of the aortic sinus or aortic root. It just deviates and arises from the pulmonary trunk. So it is called Al Kappa, anomalous left coronary origin from the pulmonary artery. Okay, there can be Al-Raka as well, which is also anomalous right coronary origin from the pulmonary artery, but this it is extremely rare. But Al-Kappa is less rare, although it is also rare, but it is significant because it is also associated with sudden cardiac death, and it is it needs to be corrected as well. So if you look at this cardiac CT scan, you can immediately see big coronary arteries. So whenever you see big coronary arteries, so it means either there is some fistulous communication, and usually the fistulous communication is with the coronary sinus, which is here, which is this venous structure, or or there is some anomalous origin. Okay, so here it is anomalous origin from the pulmonary artery of anomalous origin of the left coronary artery from the pulmonary trunk. So this is called al kappa, and it also needs correction. So this is about coronary anatomy and things. Candidate one, can you please unmute yourself for the last time and tell us about the perfusion sites which have been explained previously?
Sir, perfusion sites.
Yeah. So we talked about right coronary artery.
Okay, sir, the right coronary artery, it travels through the atrioventricular groove, and it supplies most of the right atrium, right ventricle until the base of the heart,
Yeah.
and then it also supplies to the SA node and the left coronary artery. Sir,
And also it supplies the inferior portion of the
inferior
inferior
portion
wall
of
of the
the
left
base and
ventricle.
the yes, sir, yes, sir. And
Okay.
the left coronary artery, sir, via it divides into left anterior descending and then left circumflex. The left anterior descending supplies most of the left ventricle and reaches till the inferior portion of the left ventricle, and also the posterior aspect of the septum, and the anterior aspect of the septum is supplied by the right coronary artery. And the left circumflex mostly give the marginal branches, which supplies the left side of the heart.
Okay, good. Thank you, candidate one. You have given really good viva. Best of luck for your exams. Okay, you can mute yourself now.
Thank you, sir. Thank you so much.
Thank you. Just to recap, so left anterior descending will supply most of the anterior portion of the heart and part of the septum, while the left circumflex will supply the lateral wall of the left ventricle. Okay, and the right coronary artery will supply the right ventricle as well as the inferior portion of the left ventricle. I have revised this because this is important for our next cases. I will stop share and I will share my presentation again. Candidate number two, are you with us?
Yes, I am. Good evening, sir.
Okay, thank you. Good evening to you as well. Thank you. Okay, I will go back to my presentation. So we have discussed these things. Now moving towards, these are some of the, as I wanted to cover FRCR exam as a complete package. So these are some of the 3D rendered imaging of the coronary arteries. So it can come in your FRCR1 anatomy portions. Okay, the major thing to know about it is the right coronary will always have a separate origin, while the left circumflex and the left anterior descending arteries will have a combined origin. So this is how you differentiate from the right and the left side. They can be rotated as well, so they can come in your FRCR1 anatomy portion. Sometimes they can give you some coronary conventional angiograms as well in your FRCR anatomy portion, so you need to know the anatomy around it as well. So this is the left circumflex. So again, if two big arteries are arising from a single artery, it means this is the left system, it is the left main artery, and here how this artery curves, and the left anterior descending artery usually goes anteriorly like this up to the cardiac apex. Okay, so these are different 3D rendered images. There is one important landmark or one important anatomical variant which can come in FRCR1 anatomy exam, which is called ramus intermedius vessel. So sometimes a left main artery, instead of bifurcating, it can trifurcate into three vessels. One is the left anterior descending, the other one is the left circumflex, and the third branch is called the ramus intermedius. So this is one of the anatomical variant which can come in your FRCR1 anatomy exam. So again, the same different here you can see ramus intermedius as well. So these are for your anatomy exam. Here you can see this is another anatomical variant in which there is separate origin, although it is extremely rare, separate origin of the left circumflex and the left anterior descending coronary artery. So there is no left main coronary artery. Okay, so this is something for practical purpose, we usually, when we report cardiac CT scans, we look at the curved MPR images. So these are called curved MPR, multiplanar reconstruction images of the coronary artery, so that we can see the whole coronary arteries in their entirety, the whole course. We can see any areas of narrowing and occlusions. So although they have a tortuous course, but because of this curved MPR images, you can see through them completely in a single image. These are again some curved MPR images. These are of the right coronary artery. So these are the divisions of the right coronary artery. I will not go into details. I will just tell you one thing. So this is the right coronary artery arising from this right coronary cusp at 12 o'clock position. It goes, these are the different bends, these are the acute marginal arteries, and it divides into posterior descending artery and left ventricular branch, PLB. Okay, so if both of these branches are given by the right coronary artery, so it is called as dominant right coronary artery, and 80% of the cases the right coronary artery is the dominant vessel in the coronary circulation. In 10 to 15% of the cases, this posterior descending artery is given by the left circumflex coronary artery, as it is being shown by here. So it is the left posterior descending artery. So posterior descending artery usually defines the dominance of the coronary system. So it is usually an MCQ, or it can come in your anatomy exam as well. So, or it can come as an MCQ in your FRCR 2A exam. So posterior descending artery is the defining artery of the dominant system of the coronary circulation. So if posterior descending artery is from the right side, it is the right dominant circulation. If the posterior descending artery is from the left coronaries, like LCX, so it is the left dominant circulation. And in 5 to 10% of the cases, there can be co-dominance, in which there can be two posterior descending arteries from the right and left coronary systems. Okay, so this is just to simplify this. Sometimes they say that if the posterior descending artery is from the right side and this posterior left ventricular branch is from the left side, this can also come in co-dominance. But usually the posterior descending artery is the defining artery for the dominance of the coronary arteries. Okay, so this is for your FRCR 2A exam. Okay, so far we have covered these things. So we have covered the cardiac or coronary anatomy, we have covered the malignant course, and we have covered the perfusion of the coronaries, and we have covered the L kappa, which is anomalous left coronary artery from the pulmonary trunk, pulmonary artery. So this is again regarding the perfusion. So you have three coronary vessels, LAD, RC, and LCX. So as has been described through the anatomy, so these are the different sections of the cardiac myocardium. So if this is the long axis or the vertical axis, if I cut here, this is the basal section towards the base of the heart. Okay, so if I cut here, this is the apical section towards the apex of the heart. Okay, and if I cut in between, this is the mid section. So these three are this one, the larger one, is the basal section, which is close towards the base. That's why it is larger as well. Then we have a mid section, and then we have an apical section. So these are the three sections. So if you see anteriorly and towards the septum, this is the distribution of the LAD. So if there is any abnormality in this area, so it means it is affecting the distribution of the left anterior descending artery, because as we have seen that the LAD goes anteriorly. Even the A in LAD stands for anterior. Then you have seen the LCX, left circumflex artery or branch. You see, and you saw how it goes laterally towards the lateral wall of the left ventricle, and it supplies the lateral wall of the left ventricle. So this is the distribution in red is the distribution of the LCX. And here you see the distribution of the right coronary artery. We saw that right coronary artery, it moved inferiorly and posteriorly, and it gave off two branches. One was posterior descending artery. So the name P also stand posterior or inferior. And the other one was left ventricular branch. So it supplies the inferior portion of the left ventricle and some part of the septum as well. So usually this is the distribution, and the last portion is the true apex, which is supplied by LAD. So if there is any abnormality in the true apex, it is due to LAD. So this is the general vascular distribution or perfusion of the left ventricle or heart, which is really important. And this is how these are supplied by different arteries. There can be some overlap, especially depending upon the dominance, but this is the generalized distribution which you should remember. Okay, here this is the same distribution is shown in the CT images. So these are the basal slice or basal cuts. Here you can see this is the right ventricle and this is the left ventricle. These are the mid cuts. Here you can see the right ventricle, the left ventricle. How to recognize that this is the basal cut, this is the middle cut, this is the apical cut, is that usually in the mid cuts you can see the papillary muscles of the left ventricle. Here you can see the papillary muscles, and the apical section usually will be smaller in size because it goes towards the apex, it becomes smaller, and the basal section will be the biggest section, usually the largest section. Here this anterior distribution is by the LAD. This inferior distribution is by the RCA, and this lateral wall distribution perfusion is by the LCX, and then the true apex is supplied by again LAD. So this is the vascular distribution in terms of the CT scan. Now moving towards our next portion, which is the MRI. So here this is a chart for MRI, and this is extremely important because I call this the cheat code for MRI. So here there can be basically the cardiac diseases can be divided into two main categories. One is ischemic heart disease, which are very common, and the other category is like a waste basket category. All other things except ischemia, which is the non-ischemic category. A non-ischemic category will have cardiomyopathies, also systemic heart diseases, and also other diseases. So all other diseases are categorized as non-ischemic, which can be related to chemotherapy, which can be related to cardiomyopathy, which can be related to sarcoidosis or amyloidosis. Okay, while we have another portion which is the ischemic. So the easy way to remember is to just remember the ischemic variety. Okay, just these three things, and the rest of it is non-ischemic. So any pattern which is not like ischemic pattern, it is non-ischemic. Okay, so usually when there is ischemia, it involves the subendocardium. Okay, so it will cause subendocardial enhancement. So again, this is for FRCR 2A exam. So whenever there is myocardial ischemia, it will cause subendocardial enhancement, okay, in the vascular territory. Okay. Or it can cause transmural enhancement, which is the complete involvement of the wall. Here you can see this is the subendocardial. So this is the subendocardial, this is the mid myocardium, and this is the epicardium. Okay, so if it involves the subendocardial portion, so it is called subendocardial enhancement. So if it involves all the layers of the myocardium, it is called the transmural enhancement. Okay, and it can be involving complete territory. Sometimes it involves focal involvement or focal transmural enhancement. So just remember these two things. Either the enhancement can be subendocardial or it can be transmural. So if there is subendocardial or transmural enhancement, it means it is involving a vascular territory. It means it is related to ischemia. So if there is a delayed subendocardial or transmural involvement, so it denotes ischemia. Candidate number 2. can you unmute yourself, please?
Yes.
Yes, so candidate number two, what do you think about this pattern of enhancement, and what do you think which vessel is involved?
Yes, because it's involved the septal wall, subendocardial, in the diffusion. I think this is the territory of the right coronary artery.
Okay. Do you see it is also extending anteriorly as well? This is the anterior portion. Can you see
Yes.
here?
Yeah.
So we discussed that anterior portion is involved by the LAD. So this is septal as well as anterior, and also this is anteroseptal more. So this is involving the subendocardial enhancement. So this is myocardial MI of the LAD territory. Okay.
Yeah.
Okay. So again, regarding this, about this transmural enhancement, can you please comment on this? Which vascular territory is involved?
This involved the circumflex coronary artery territory.
Yes, excellent, excellent. So this is a late gadolinium image, okay, and it shows transmural enhancement of the lateral wall of the mid ventricle, and because you can see papillary muscles, so of the mid cavity, and it is involving the LCS territory. Okay, this was involving the LAD territory. So if there is an inferior wall enhancement as well, so it will involve the RCA territory. Okay, so this is the ischemic pattern. So it is either subendocardial or transmural. Rest patterns, it can be mid wall, it can be subepicardial, it can be diffuse as well. So all these patterns are non-ischemic patterns. Okay, so most common is the mid-wall pattern. Okay, so these are non-ischemic patterns. So differentiate between ischemia and non-ischemia. Rest pathologies are simple. Okay. Now I would like to talk about certain MRI. Cardiac MRI is a difficult topic for FRCR 2B exam, and I hope it is not shown much in the FRCR 2B exam because it is can be extremely challenging as well. But again, my tip will be always focus on anatomy. So pathology is abnormal anatomy. If you know the sequences, if you know the anatomy, the cardiac MRI is extremely easy. Okay. So here are some of the basic sequences of the cardiac MRI. So we have axial haste images, which are done for anatomy. Sometimes we also do some white blood images. So if you can see the blood, which is white in color, we call them as white blood images. Okay. Um, they can be SSFP images as well, but we usually call them, you can easily call them white blood images. Okay. Then we have different views of the heart. Just to highlight, heart is obliquely placed inside the chest cavity. Okay, it is not in a horizontal location. So we usually take true axis images through the heart. So we align the axis along the direction of the heart. So we take true axis images, like this is the short axis or true axis images of the heart. Here you can see the right ventricle and the left ventricle. So these are the different slices of the heart in the true axis or the short axis. Okay, here these are the long axis images of the heart. Here you can see the whole of the heart. You can see right atrium, right ventricle, left atrium, and left ventricle in a single image. So these are called the long axis images. So we can take long axis images of the left ventricle separately as well. We call this as this is the left ventricular two-chamber view. Okay, so we take short axis images, we call them as short axis images. We call this as the left ventricular two-chamber view, and this is the four-chamber view. Okay, and sometimes we take a three-chamber view as well. Okay, so I will show you that. So we have different chamber views. So short axis, two-chamber views, four-chamber view, and three-chamber views. We have some edema sequence, which are usually stir RT2 star images, and we have post-contrast images. Usually in cardiac MRI, we take two types of post-contrast images. Unlike other post-contrast images in cardiac MRI, late post-contrast images, which are usually done after 10 to 15 minutes, are extremely important, and I call them the cheat code. These are all late gadolinium sequence. If you are asked what is the most important sequence in the cardiac MRI for FRCR2A exam, it should be the late gadolinium sequence, because it will tell, you will diagnose most of the things on this sequence. Then we have an early gadolinium sequence as well. Again, this early gadolinium sequence can be used to rule out any cardiac thrombus, or sometimes it is used to rule out any acute myocardial infarction. Okay. So these just are the basics of cardiac MRI sequences. There are further extensive MRI sequences like T1 and T2 mapping, some perfusion sequences. I will not go into details of these sequences because I think these are out of scope for the FRCR2B exam. Again, coming towards the distribution of the myocardial infarction. So candidate number 2, can you please unmute yourself?
Yes.
Yes. So here you can see different sequences. So these are the late gadolinium sequences. These are the SSFV or the bright blood sequences, and these are the T2 stir or the edema sequences. Okay.
Yeah.
Just focus on these sequences, lower sequences. Okay. Here you can see in enhancement in which area?
This is a territory of the left anterior descending coronary artery.
Okay, good. And because it is involving the septum as well as the anterior portion. Okay.
Okay.
Yes. And what about this?
Yes, I think this is a transmural delay enhancement, which is seen in the territory of the circumflex coronary artery.
Good, excellent. So it is involving the lateral wall, hence the territory of the circumflex. Okay, excellent. And what about this?
This one involving the inferior wall of the myocardial transmural enhancement, and this is representing the right coronary artery territory.
Good, excellent. So candidate number 2, the other tip for your Viva is just always look at the corner of images. And if you look at the corners, all these things are written here already, but I know you gave the answers out of your concept and knowledge. There is also conventional angiography images showing these different narrowings, areas of narrowings of these portions. So excellent. So I think we are now ready for the cases. Okay, let me share the screen again. Okay. I will share my screen just for the case. Can you see my screen, candidate number 2?
Yes, I can. Yes.
Okay. So here is the anatomy sequence. Do you want to scroll? I will scroll it for you initially.
Thank
I will
you.
scroll
Thank you.
for you. Okay. I think it will be easier. So these are the white blood sequence. Okay. We initially do a white blood sequence. We cover the whole area to look at the anatomy. We look at the connections, the vascular connections. So here you can see aortic arch. And this is the conventional branching pattern of the aortic arch, where you can see brachiocephalic artery, left common carotid artery, and left subclavian arteries. Here you can see SVC, and this is the pulmonary trunk, ascending aorta, descending aorta. There are multiple lymph nodes you can see here. And this is for to look at overall anatomy. You can see some simple hepatic cyst, and just ignore them. Okay, so this is an overall image. Sometimes we take haste image, sometimes we take this white blood image to look at the overall anatomy. Okay, now I will move towards the cardiac images, and I will ask you what are the sequences. Okay.
Okay.
So let me show you this sequence. What do you think? What is the sequence and what is the anatomy that are you showing on this sequence?
Yes, I think this is a sequence of cine images, T2, four-chamber view that showing both atrium and both ventricles taken in axial.
Good. Good, excellent. So we call it as four chamber views, okay? And usually it is a white blood image. And yes, you are absolutely right. These are cine images, and you will be able to see the valves as well. So this is the mitral valve between the left atrium and the left ventricle, and this is the tricuspid valve, okay, on the right side. Okay, so there is no there is minor mitral valve regurgitation. You can see a tiny bit of jet flow here. Otherwise, there is no significant regurgitation or insufficiency. Okay, now you have seen the four chamber view. So what is this view?
This is also cine images, two chamber views for the left ventricle and the left atrium. Here I can see in the cine images the aortic valve, and I can assess if there is any regurgitation or not.
Okay, so good. This is the mitral valve. This is not the
Sorry,
aortic
mitral
valve.
valve.
I will show you the aortic valve. So between left atrium and the left ventricle is the mitral valve. Okay. Here you can see in this small amount of jet there. So probably some regurgitation is there. Things. Okay. And you can see the papillary muscles as well. So this confirms that this is the left ventricle. In right ventricle, you won't see these kind of papillary muscles. The left ventricle is also thick walled as well. You will see a moderator band in the right ventricle, which is used for identification of the right ventricle. So, yes, candidate number 2, what do you think? What do you see?
Yes, this is a three chamber cine images because I can see also here the right ventricle. Also, I can see the right atrium and the the left atrium, left ventricle, and right ventricle.
Good.
Three chamber view. Yeah.
Yes, so you see the left atrium, the left ventricle. This is the left ventricle outflow tract, and this is the proximal aorta. So this is the aortic root. Usually, aortic root has 3 segments. It has one, this is the sinotubular junction. Okay, so it has this middle bulbous section, which is called the sinus of Valsalva. Okay, it has an inferior portion, which is called the annulus. So it has annulus, this is sinus of Valsalva, and this is the sinotubular junction. And from this commences the then ascending aorta, the tubular portion of the ascending aorta. Okay, so this is the left ventricular outflow tract. Here you can see this is the left ventricular outflow tract, and this is the aorta. And you can see part of the right ventricle as well here. So this is the 3-chamber view. So here you can see a slight thin jet. So this shows the mitral insufficiency, minor mitral regurgitation, and the 3-chamber view is the best view to look for the mitral regurgitation. Okay. So now I'm showing you another image. Okay.
Yes, this is a stair sequence, short axis, that showed that there is increased signal intensity seen in the inferior wall and in the inferior lateral wall of the myocardium of the left ventricle, which are representing edematous changes. And I can also see that there is increased signal intensity also within the right ventricle, these representing edematous changes.
Excellent, excellent. Candidate number 2. So as candidate number 2 explained, so this is the inferior wall, and you can see edematous or high signal intensities in the inferior wall extending towards the septum as well as the lateral wall. So this is the diaphragm. Okay, so sometimes the images are taken like this. So if the part of the myocardium which is on the diaphragm, this is the inferior wall. Okay, sometimes these are called anterior and inferior junctional points, and you can draw some lines from these, and from there you can also differentiate between inferior and lateral wall. But to simplify things for you, if it is uh, sitting on the diaphragm, it is the inferior wall. Okay, so the cardiac anatomy is also slightly different. This is the anterior wall, and this is not the posterior wall, this is the inferior wall. Some people also call it as the posterior wall, but the standard ACA terminology is this is the inferior wall. Okay, and then we have the septal wall and the lateral wall. Okay, we have the lateral wall, we don't have the medial wall, we have the septal wall or septal segment. Okay, so anterior, inferior, septal, and lateral walls. So excellent description. Now I will move towards the most important ortho sequence, which is the late gadolinium sequence. Now, candidate number 2, can you explain this, please?
Yes, this is a short axis post contrast late gadolinium sequence that showed that there is a transmural delay enhancement seen involving the inferior wall extending into the septal wall and into the lateral wall. I think this is taking in the vascular territory because I can see that the rest of the myocardium appears grossly normal without any delay enhancement. So I will make this within the ischemic category of the cardiac MRI, and mostly it involves the right coronary artery territory. Appearances are those of myocardial infarction.
And is it acute or is it chronic?
Because it is transmural, I think it is acute. In my routine practice, I will also search if there is any microvascular obstruction, which is a non-enhancing area seen within this enhancing area, which also indicate the acute of the MI.
Good. Just I will correct you once. So you had seen there was edema. On edema, there was active edema. So if there is active edematous changes, it means it is an acute myocardial infarction. You don't have to look at the microvascular obstruction. Before that was that if there is acute edema, so it means there is acute myocardial infarction. If there is chronic myocardial infarction, there will be wall thinning. There will be no myocardial edema. And as you rightly said, there will be no microvascular obstruction. So you were talking about microvascular obstruction. Let me try to show you microvascular obstruction as well. So for the rest of the candidates, so microvascular obstruction, these are the early myocardial sequences. So the difference between early and late late gadolinium sequence is that in the late sequence, the myocardium is nulled. It is completely black. While in early gadolinium sequence, you can see the myocardium is not nulled. Okay, it is just taken after we give the contrast. Okay, and if you see a hypointense signal abnormality along the surface of the endocardium, it means there is microvascular obstruction. It means that there is acute myocardial infarction with a worse prognosis. If there is microvascular obstruction, it means the prognosis of the MI is worse. So this is something that you can see on the early career. So this again an FRCR2A exam MCQ. If you want to see for microvascular obstruction, the best sequence for microvascular obstruction is the early gadolinium sequence. You can sometimes see it on the late gadolinium sequence as well, but the best sequence for that is early gadolinium sequence. On early gadolinium sequence, we usually look for two things. Number one is this microvascular obstruction. Number two is thrombus. Any thrombus, it will be non-enhancing on the early perfusion images or early gadolinium sequence. While if it is a mass or it is a metastatic lesion, it will show some heterogeneous, either heterogeneous or homogeneous enhancement. So these are the uses for early gadolinium enhancement. I'm sorry, it is too much to take in, but candidate number 2, you have done really well. You have done everything well. In case of acute MI, I think most probably they will already know, but still you need to call the primary physician and tell them about this finding because the patient has acute MI as well as the patient had microvascular obstruction. So it has a worse prognosis for this MI. Okay. So candidate number 2, well done. Now we will take a 5-minute break, and at my watch the time is 7:35. I will rejoin by 7:40. Okay. Okay, candidate number 2.
Okay, thank you.
Thank you.